So you remember at the end of my first presentation, we talk about the actionable mutation, but we talk at the non-actionable mutation, and we said that this may be the area of BDL1 inhibitor. That's why we will talk about the BDL1, as I mentioned here. So this group, 25 and 31, like 56% of lung cancer still don't have actionable mutation. So this group, fortunately, they might have a good option for treatment if they test positive for BDL1. That's why many companies run for trying to do a clinical trial on using BDL1 inhibitors, like, and the trial became famous, like Keynote, Checkmate, Mystic, Empower, and many are coming. And immunotherapy could be a monotherapy, or combined with chemo, or chemo combined with immuno, like immuno. I will talk briefly about about them in a minute. For monotherapy, you have the 4 player still in the market: Pembro, Atizo, Nivo, and Durva, and every one of them, they have famous trials that get them approved in FDA. The first trial was a Checkmate 2.6, and in this trial, this was among the early trial in immunotherapy, and it done by BMS. They use nivolumab, they randomized patient with stage 4 recurrent non-small lung cancer with no prior therapy, with BDL1 more than 1%, with wild type EGFR and ALK, to receive either nivolumab or investigator choice. And the primary endpoint was BFS, and secondary endpoint were overall survival. Unfortunately, this trial did not show benefit and did not reach its aims, so it's a negative trial. The second trial is Keynote 24. It's very famous trial. Same patients, stage 4, wild type EGFR, ALK negative, BDL1. Here is the difference: BDL1 more than 50%. This is very important. And of course, ECOG 0 to 1, no prior therapy. And this patient has been randomized equally to Pembro every 3 weeks, 2 years, or platinum doublet chemotherapy. And these patients could have option to maintain brimetexted or Alimta until progression. And they look for BFS and second endpoint overall survival. This study was very successful study, and as you can see, in both in first presentation and last year, they published the update of it, and as you can see, there's a hazard ratio of 0.50, and there is 50% reduction in progression-free survival, and the p-value was 0.001, and you can see that the median BFS was 10 months versus 6 months in favor of immunotherapy. And this is translated into overall survival. As you can see, at 4 years, you have double the survival when you use the immunotherapy versus chemotherapy. Again, the overall 5-year survival maintained with 32% versus 16%, double the survival. Very famous trial, very nice. One of the amazing trials in the recent years. Keynote 42, the last one 24, so this is 42. They done the same, but they're trying to recruit more patients with less BDL1. So they choose patient with BDL1 just more than 1%, not more than 50% as they did. And they randomized that to receive Pembro, or they define here the chemotherapy, carboplatin, AUC5, and paclitaxel 200 milligram per meter square, or Pemetrexed instead of paclitaxel. And again, they look for overall survival in PDL1 more than 50, PDL1 more than 20, and PDL1 more than 1%. And the second endpoint was the BFS. As you can see in the at your left hand here, this is the overall survival in PDL1 more than 50, and you can see clearly the same benefit we see in Keynote 24. There is the difference in survival, significant difference, 20 months in median survival in immunotherapy versus 12 months in chemotherapy. And this survival is still there in PDL1 more than 20, and in more than 1% also there is there, but the hazard ratio became less. Regarding the BFS is still also in more than 50, we have a nice BFS with hazard ratio 0.8, and but we lose this benefit when the PDL1 became less than 20 or became less and less. In this graph, we don't have a benefit if you have just more than 1% PDL1, as you can see here. So PDL1 more than 50 or more than 20 is important to have a control. MYSTIC is a new trials, and today I will just show the first result comparing the overall survivor between the Dorvi and the chemotherapy. In this trial also same principle as before, stage 4 non-small lung cancer, PDL1 will be a subgroup, and EGFR wild type, immunotherapy and chemotherapy naive. And as you can see here, there is a good difference between the immunotherapy and chemotherapy, but it was not statistically significant. And these people using different p-value to prove if it is statistical significance or not. So, as you can see here, the 0.03, but 0.036, but they put a p-value of 0.3, and that's why it's not statistically significant. Now we come to the monotherapy from Roche. This is a new result of a trial published last year in Barcelona, in ISMO. And in this trial, they compare atezo versus chemotherapy cisplatin based, and they select patient according to PDL1 to receive atezo or cisplatin, and then maintain with atezo. And as you can see, and they look for overall survival as a primary endpoint, and the second endpoint was a BFS. They look for different, as Keynote 42, they look for different response to different PDL1 level. As you can see here, this is the characteristic of the patients. They all equal. And here is the PDL1 expression. Of course, all the patient has to be PDL1 positive, but this is a group with PDL1 more than 1%, and almost 40% of patient has a PDL1 more than 50%, and some 60% of patient has a PDL1 more than 5%. This is a nice result, concordance with the result of immunotherapy checkpoint inhibitor in high PDL1 tumors. And as you can see that there is a significant difference between overall survival, which has reached 20 months in immunotherapy versus 13 months in chemotherapy, and the p-value was 0.1. This forest chart showing that most patients benefit from the drugs except patients who never smoke. This is very strange. So patient who never smoke is a bad prognostic factor, but in this study, there were only 11% of the patients. But most of patients benefit from the monotherapy, immunotherapy in more than 50% PD-L1. If you look into intermediate PD-L1 expression, you will find that you have some benefit, and numerically it looks nice. However, again, the p-value is 0.4, but the proposed p-value was not 4.1, it was only 4.4. So this trial is not statistically significant. If you have a low PD-L1, you don't have any significant difference. So PD-L1 is very important if you are giving a monoclonal antibody alone. Again, this second endpoint was the BFS, and it was reached. And you can see that the difference between patient has immunotherapy and chemotherapy significantly difference in BFS value in more than 50% PD-L1. And this significance disappeared, still there in low PD-L1 level, as you can see here. You still have a significant difference in BFS, but not in overall survival. Regarding the overall response is there, and also it's higher in patients with high PD-L1. Of course, the toxicity was tolerable, and as you can see, the red color indicates the toxicity of chemotherapy, which is very high, but the immunotherapy have less toxicity, and the special toxicity here is the pruritus and the hypothyroidism. To conclude, atezo monotherapy showed statistically significant and clinical meaningful overall survival. However, in patients with 50% PD-L1, for patients with less than that, we are still waiting for the formal result of final analysis of overall survival. So atezo represents a promising first-line treatment option in patients with PD-L1 high in non-small lung cancer. This is a question of Dr. Gamal. Does PD-L1 test differ? They did it retrospectively, and they found that however you test for PD-L1, you still maintain the, if you test using SP142 or you test by 22C3 or SP263, you still have a significant difference across the line, especially in PD-L1, high PD-L1, okay? This is another trial. It's called Empower as a monotherapy also. This is a new drug, a new monotherapy. It's called semi-imibelimab. This is a drug. First, it was a monoclonal and checkpoint inhibitor for skin cancer. It has FDA approval for metastatic skin, squamous cell carcinoma of skin, developed by Sanofi Aventis. And now they try it in lung cancer, same concept as Keynote 24. They used a high PD-L1 patient with wild type ALK and ROS. And they found that there is a good statistical significant difference between monotherapy, similimumab, versus the chemotherapy. And also the overall survival is high, especially for patients with more than 50%. There is intention to treat because there is 15 patients. They added them to the trial. They were not added at the beginning, okay? But the difference is very nice as usual. What about the combination? We have Pembro and Atezo, and everyone has its trials. We have Keynote 189, 407, and Empower 150, 130, 132, 131. They all differ in the combination part of the chemotherapy. So the backbone is a checkpoint inhibitor, but the combination is different in the chemotherapy. Why we do that? Because sometimes we know that this is the immune cycle. We know that some tumors are deserted in immune response, and some tumors are having inflamed. We have more T cells, and some tumor as immuno-excluded. So chemotherapy can, when it work on the tumor or cells, it will disrupt the cells, it will release antigen, it will increase the tumor antigenicity. This could lead to increase in the effects of PD-L1 inhibitor or checkpoint. So the trial is Keynote 189. Again, same principle, and they give BEMI plus Alimta carboplatin, and this is in non-squamous cell lung cancer, or placebo, and they maintain by Pembro plus Alimta or Alimta alone. And as you can see, this is a positive trial. You can find that usually the 70% the 70% 1 year survival is standard for immunotherapy, and usually it's different from the chemotherapy by 20%. Most of the immunotherapy does that. Okay, so you don't have to memorize. And the same BFS was double for immunotherapy group, and here the response rate was triple for immunotherapy group, immunotherapy combined immunocombined chemotherapy group, and the toxicity was there, and most of the toxicity was renal impairment and nephritis. This is a Keynote 407, same drug, but this is non-small lung cancer with squamous histology. With squamous histology. And as you can see, the Pembro here we change the backbone, paclitaxel or nab-paclitaxel instead of Alimta, and we give maintenance for 31, or if you can also have option of crossover up to 35 cycle. And again, you have a nice statistical significant difference between the combined chemo-immuno versus the chemo alone. Again, the overall survival maintains a statistically significant difference. The famous Empower 150, this is very famous trials. I like it because the concept of this trial is nice. They look how to improve the microenvironment and how to target the microenvironment in favor of a checkpoint inhibitor. And in this trial, they compare the standard of care atezo carboplatin paclitaxel beva versus atezo carboplatin paclitaxel bevacizumab. This is the main item they compare. And as I mentioned, why they do that? We have a combo of atezo, which restores the anti-cancer immunity. We have a beva, which is established anti-angiogenic effect. We will talk about importance to have an anti-angiogenic effect. And you have the chemotherapy, as I mentioned, to release the antigen. The goal of combined immunotherapy is to create more favorable environment to maximize the potential of the immune system to eliminate cancer. This is the immune cycle, and as I told you that the BEVA work by recognizing the efficient priming and activation of T response, and also by normalize the tumor vasculature, so it will help. If you have more VEGF receptors, you have less infiltration of T cells. So if you normalize that, you will have more T cells to enter the tumor, and this means more effective checkpoint inhibitor. With the addition of chemotherapy, you will have more antigenicity. Okay. And also in this Empower 150, this is the only trials that added to its patient who have failed on EGFR and ALK more than one time. And as you can see here, there is a nice BFS difference between patient who received the combo, the 4 drug, versus patient who received the chemotherapy, Avastin, or the 3 drugs. And the p-value was 0.001, and the median overall survival was 8 months versus 6 months. Again, the overall survival also is significantly different, 20, almost 20, as I mentioned. Usually the median overall survival in combined immunotherapy is around 20 months. And this is the median overall survival for combo. This is a little bit higher than the real trial, the original trial of Avastin, Taxol, and carboplatin. Again, this is the first chart analysis, and you can see that all patients benefit. Patient who has liver met or no liver met, patient who has BDL1 high or intermediate or low, patient who have EGFR and ALK negative or positive, they all benefit. And the overall response was very nice here. You can see that they have 4% complete response, 60% partial response, and the overall response 64 versus the other arm. Significantly different. Again, the safety was comparable, and there is no high toxicity with the addition of immunotherapy. Instead, there is a nice maintenance of quality of life in the immunotherapy combo arm. Okay. This is another trial. We will not talk about much. Just they change the combination. Instead of carboplatin, Taxol, Avastin, they add nab-paclitaxel and carboplatin to decrease the use of cortisone. And again, we have a nice difference between both arms. 7 months median overall survival for the combo versus 5 months. And overall survival is also significantly different in combo arm versus the chemotherapy arm, with less side effect or comparable side effect. In Power 132, they change again the chemotherapy. They're using Alimta this time. And again, you will find that there is a significant difference in both arms, 7 months versus 5 months. These usually happen all across the road, with nice overall survival here, with significant difference, 18 months versus 13. This is to some extent a real one, okay? About Empower 131, here they test for the squamous cell carcinoma. They use atezo-carboplatin paclitaxel versus the carboplatin nab-paclitaxel versus the carboplatin without atezo. And they look for the overall survival and BFS. And you can see here, even in squamous cell carcinoma, the atezo with chemotherapy have a statistically significant difference, almost double the BFS at 1 year. Okay, and this is published in ASCO 1918. Okay. However, the overall survival is not statistically significant. What about the patient with EGFR and ALK and liver met? They benefit. This patient usually they don't benefit from immunotherapy, as you can see here in previous trial. The patient with ALK or EGFR, they do worse with if they first start with immunotherapy. And the reason, because they don't have more immunoinfiltration and they don't have BDL1. If you compare this to this, you find more BDL1 in wild type, higher BDL1 in wild type than in EGFR mutation. So that's why they don't do good with immunotherapy upfront. Additionally, when they try BEVA with anti-EGFR, they might have a good response, as published in Lancet Oncol 2014. You can see that addition of BEVA to Iressa or erlotinib, sorry, Tarceva. 2 minutes. So when you add Iressa to erlotinib to bevacizumab, you have a significant difference. This is the concept to adding Avastin with immunotherapy to patients who already have EGFR mutation. And that is true. And if you look for the trials, the Empower 150, you can find that patients who failed EGFR inhibitors, they significantly benefit from the combo. And as you can see, the median survival 9 months versus 6 months, almost the same as the first line one. Okay. With the overall survival also didn't reach yet. So the same for liver metastasis. Liver metastasis, it's hard to treat because patients with liver metastasis have a 54% increased risk of death versus patients with brain metastasis. Number one. Number two, patients with liver metastasis has significantly more metastatic sites than patients without liver metastasis. So this is very important. Additionally, there is a lot of VEGF expression in liver, and this will lead to increase immune suppression, increase T regulatory cell, decrease immune cell filtration, decrease the VCAM expression, decrease immune activation. So all of this have led that the combination of immunotherapy with VEGF could be a good option, and that's true. And you can see that BFS was 8 months for patient with liver met versus 5 months with patient with liver met using chemotherapy alone. So this is very nice here, 13 months versus 9 months. So finally, we have a very good option for patient with liver metastasis and good option for patient who failed EGFR and ALK. Thank you.
Thank you very much, Professor Walid Arafat, for these 2 elegant presentations. Unfortunately, because we are running out of time, we'll close the session now. And Professor Salam.